Thank you very much, Chris. I'd like to start off by introducing my other panelists. First of all, Theresa Gallivan, one of the Associate Chief Nurses at Mass General. Second, Karen Reilly from the Brigham and Women's Hospital. And third, Dr. Ross Zafonte from the Spaulding Rehabilitation Network. All of these clinician leaders have played major leadership roles during the COVID-19 response here at the Partners Healthcare System, or as we're now referring to ourselves as the Mass General Brigham System. I would start off by saying that we have had a long history of preparedness for emergencies in each one of our individual institutions as well as across the system. And one of the things that I think has really been an important component of our response to COVID-19 was this preparation. One of the critical tools that's embedded in our emergency preparedness plans is a structure called the Hospital Incident Command Structure that represents that is also utilized in our public servant agencies, such as fire, police, and emergency medical services. That allows us an opportunity to move from our traditional, very collaborative and consensus-building approach to decision-making to one that really now moves into command and control, which was absolutely essential in any type of an emergency preparedness scenario, but particularly so in this case. We started off in a situation where we knew very little about this virus, other than the fact that it was dangerous, and there were many, many questions and many fears, as well as the fact that we knew we were going to be dealing with something very longitudinal. And this was certainly way before anybody called this a pandemic. So with that in mind, we really needed to start preparing our institutions for the onslaught of victims of this disease, as well as the fears and concerns of our workforce, families, and colleagues. So with that in mind, as Chris has alluded to, there was an awful lot of innovation and new ideas, new creativity that was launched throughout our system. And my panelists today are going to share some of those great ideas with you today. So I'd like to start off by asking everyone the first question: what was the most creative idea that the team that you were helping to lead developed, and what was the clinical problem in the delivery system that you were trying to solve by this idea? And I'm going to start with Karen. Would you be kind enough to comment on that?
Sure. I think there were several things that this onslaught of COVID-19 patients brought to us at the Brigham. And I think what happened is it fell into 4 different components of what we needed to find innovation for. It had to do with PPE, it had to do with staffing, and then it had to do with communication in and outside the rooms. I think the biggest challenge that we found in the very beginning was when you moved into and I covered the critical care areas, and I still do, was the ability to speak outside the room. You had nurses and you had physicians in full, complete PPE, and behind a closed door in a negative air pressure room, every single one of the patients on that unit, and the ability to speak to the staff outside the room and get what you needed to help care for the patient became a huge challenge. And also, we were also facing not only the onslaught of patients, but we were also facing lack of PPE or conserving PPE. And so we were trying to decrease the amount of time people were coming in and out of the patient's room. So one innovation that we did come up with was a video intercom system that used an iPad in the room that was always on, and then out at the nurse's station, out at the desk outside the room, the nurse could do face-to-face communication with the patient or with another staff member in the room. And this really helped with their ability to communicate back and forth with each other while not having to go in and out of the room, and also not having to remove PPE off and on, donning and doffing in and out of the room several times. So this was really a big innovation for our staff, as well as we also implemented Voicera, which is a hands-free communication device, which became integral in our ability to speak to one another and care for our patients.
Thanks, Karen. Theresa, can you comment on some of the innovations that you helped oversee at the Mass General?
Sure, Ann. I think the creativity that we had to exercise around staffing is probably the most significant. The rapidly evolving demand for ICU care for patients with COVID-19, and furthered by the modeling projections for our hospital and system, called for an additional 123 ICU beds at our hospital, Mass General alone. That's a 92% increase, and under normal circumstances would translate into a need for 500 new ICU nurses, with 12-plus weeks of orientation and training, given the myriad of interventions and technologies that we see in our ICUs. Nurse executives and ICU leaders came together to review the literature for established approaches and found little. So in response, we developed a partnership model to leverage our existing ICU nursing expertise. We would extend ICU nursing to additionally critically ill patients. Of course, this meant pulling general care staff from those units, which were also in great demand. So in response to this, we brought ambulatory, procedural, and OR nurses to partner with those staff. In the end, we deployed about 700 nurses, really almost overnight. This was a huge challenge. Nurses had many questions, not only about the unknowns of caring for patients with COVID-19, but also about how they would obtain the skills and knowledge to practice safely in those dramatically different care environments. In the end, they've met the challenge. They've responded with grit and grace, and they continue to meet the demand for high-intensity care. It goes without saying that the success of this innovative model was and continues to be highly predicated on the support of extraordinary frontline leaders, nurse educators, MDs, and colleagues across all of our disciplines.
Thank you, Theresa. Ross, how were things in the rehabilitation network with respect to this question? Creative ideas that you and your team developed to deal with the challenges that were faced in care delivery.
Ann, thank you. It was really an incredible, broad team effort. And we thought quickly about, hey, we have a large group of people who are going to have long-term issues, mobility, cognitive, other issues. How do we build a home care system that is flexible and pliable, facile with PPE, educate them and get that to where it can take care of hundreds of people? And then we thought, a lot of these people are going to need long-term acute care. And so within Cambridge, that team there built a tremendous series of units that were able to involve people and take in people who had a number of disabilities, ventilatory needs, and other needs. In Spalding Brighton, we had to think about the at-risk population. How do we go about really defining who is at highest risk, targeting those people, and perhaps isolating them? And lastly, at Boston Hope, where we collaborated with others, how do we develop an effective offloading for our acute care colleagues? So it was multi-pronged and collaborative in its entire extent.
Thank you to all of you. I think one of the other important things I'd be remiss not to mention is how much we as a system really learned to work together and to rely on one another's expertise in putting all of these different plans together. And one of the important innovations I think that we took large advantage of was the opportunity to do modeling with respect to experiences that had taken place already ahead of us in different parts of the country and quite frankly in the world, which I helped position us to think about what the worst case scenario would be and plan for accordingly. But when we think about some of these innovations going forward, what are the ones you think really have legs? What are the ones that we should continue to make sure that we keep the momentum, build upon further? And maybe I'll start with Theresa this time.
Sure. There are many because we've learned so much. Four that come immediately to mind are that we will continue to create more opportunities for staff to train and be prepared to flex across specialties and levels of care. That comes with challenges beyond training, but it's something we'll need to do. Interestingly, in more controlled circumstances, I think staff would welcome this more than we might have otherwise thought. This is the feedback that we've been getting. Ongoing emphasis and training on infection control and PPE. We need to prepare to care for COVID patients just as we care for patients with COVID-19, just as we care for any other patient that requires isolation. We are already working to design and improve systems for safer and more controlled management and access to PPE at the patient care unit level. Ongoing incorporation of technology that continues to support distancing without negatively impacting quality of care or the patient care experience. As we've seen in this current crisis, patients and families are ready to fully embrace this technology, probably more so than we as healthcare providers have been. And finally, I think, and most important of all, a much greater emphasis on priority setting and alignment of efforts across disciplines. A shared agenda has proven to be a very powerful thing. The one presented by COVID-19 pandemic has inspired and reminded all of us of what it really means to be in this together and what that can mean in terms of producing results. I believe it's critical that we learn from this experience and moving forward that we continue to prioritize and align our efforts, and that we're going to have to if we're able to keep pace with the rapidly changing healthcare demands as well as healthcare provider needs in the future.
Thank you, Theresa. Ross, what would you add to that?
So I think Theresa's response was great. I would add the following. You know, we've learned a lot. We've heard a lot about telecare today, but telerehabilitation is an enormous opportunity. And we recently did a study that basically showed non-inferiority in the stroke rehabilitation population. So there's a place I think we can emphasize and grow. Flexibility and systemness. We've all sort of learned how to be Mass General Brigham. And how do we take the good parts of that and leverage it further? And then, most importantly to me, is we really learned from this disease that there are social disparities and there are other disparities. Those are disability. Those are people in skilled nursing facilities. How do we think prospectively about identifying hotspots, using data that is mostly bereft in nursing homes, and really trying to figure out how can we inform ourselves to reduce that risk, optimal spacing, early signs, biomarkers, thermal temperatures within facilities. How do we identify a hotspot and manipulate it awfully quickly? And I think we're learning a lot about that.
Karen?
I would echo both what Theresa and Ross say about our ability to collaborate and move ideas quickly forward. I think that this pandemic really challenged us to, while it's great to collaborate, where is the point where you see the problem and then you move forward? I think things that we've used technology much more, people were very leery of technology in the past. I think we really elevated the use of technology and communicating with our families because we had to when we had to restrict visitors. I think looking at how we use the interdisciplinary team, we put together a proning team because this was something that we needed to do a large amount of with our patients on the units, and using our physical therapy colleagues, we were able to effectively get that done. It requires a lot of manpower. And there were many examples of where the interdisciplinary team came together for one problem and we were able to solve and find solutions very quickly during the last 8 weeks.
So what would you do differently? Knowing what we know now, are there things that you would do differently from the roles you played, or you would advise your institution or anyone across the system to do differently based on what we know now? And Ross, maybe I'll ask you to start this time.
Sure, thank you, Ann. Well, I mean, I think an earlier systemness needs to be part of our genomic core from now on. I think we're going to face challenges again. And part of what we can learn is putting the right person to the right care at the right time and getting a little bit away from our siloed obstacles, and then identifying those at greatest risk in our communities and in other settings. And how do we intervene just a bit earlier where we can save lives and improve function? And then most importantly, I think in many ways, is how do we stay ready? So if it's not COVID-19, it's likely to be another event in the near future, or perhaps some catastrophe of one format or another. This remarkable institution and community have always responded in a special way. I think we'll need to be more ready than ever.
Karen?
I would say the same as Ross, is being ready. I also think that I wish I had, we started on a small scale. I think we didn't understand the large scope of what the surge was going to be. I think we were a little delayed in reacting to that. And so we started on units on a smaller scope and then quickly realized that the surge was coming, and then we're rapidly trying to prepare. So preparedness probably was one of the key things of trying to stay ahead of the curve of what we needed.
And Theresa?
I would say, similar to my colleagues, and add that from my own perspective, I guess it would be never to underestimate the extraordinary creativity of our colleagues. The problem resolution that evolved over such a short period of time was truly remarkable, from very sort of focused problems to much greater ones. I'm thinking about the challenges that we had as we began to care for so many intensive care patients in non-traditional areas and spaces, and not having alarms integrated from our ventilators, for example, and how nurses and other clinicians, respiratory therapists, physicians came together, identified a program whereby we tapped into the hospital labor pool and pulled non-clinicians in to serve as listeners, training them to be listeners and to notify the clinical staff when vent alarms would be sounding, until such time as our biomedical engineers could come in and create something more long-term. But it was really remarkable. Things that you would think would maybe bring a plan to a grinding halt repeatedly, our colleagues were able to come up with solutions.
As we were chatting a little bit about earlier, clearly we are not through this yet, and one would say that we are still on the tail end of the surge. And I think all of our modeling experts, both internally and externally, have advised us that coming down from surge probably takes at least twice as long, if not 3 times as long, as going up to get to those surge numbers of patients that we collectively have cared for. I guess when we start to think about recovery planning, and we are in fact all doing that both as individual institutions and across our system, I'd ask each one of you to just reflect a little bit upon, what do you think the new normal is going to look like from the vantage point of your own institution? And as you've all alluded to or stated even explicitly, it's important, this preparedness, should we have a second surge. But maybe give a little bit more detail in terms of what that means in your own mind and based on your own experiences. And Karen, let's start with you, if we could.
Yeah, I think right now we're in the middle of transition, right? And what is the new normal? The new normal, I believe we're going to need lots of flexibility. How are we going to take care of patients when we increase by 20 ICU patients that we weren't expecting as the surges go up and down, the peaks and valleys? I think we're going to have to be strategic and creative in how we make sure that we have staff to be able to care for that, but also patient care areas that will be able to expand and decrease based on the patient needs that we have. And I think moving forward, what are we going to do about visitors? How are we going to interact with our patients and our families? When will we be able to start to see people come back into the hospital? And as we do this slowly, I think we're going to have other challenges that we haven't even been thinking about, because that's the one thing I've learned from this entire pandemic. As prepared as we think we are, there's always some new problem that pops up that we've had to creatively address.
Thank you. Theresa, would you like to add some comments?
I would just echo everything that Karen has mentioned, and probably just also suggest that before we get to the new normal, we have this interim period where we have so much pent-up demand for providing care to patients that can no longer be deferred, the patients that we haven't been able to respond to over the last couple of months. So that in itself is sort of giving us another test of our capabilities around balancing the equation and continuing to provide care for patients with COVID-19 disease, and at the same time respond to the patients that have urgent care needs to whom we would normally be responding. I think that this purpose around more cross-training and more readiness of staff across all disciplines to transition from one care environment to another is going to be absolutely critical to some of that.
And Ross?
So I agree with my excellent colleagues, but I would just like to add a few points. One, how do we integrate perhaps a little bit better and think about things in a system this way so it's more of a integratory function than a series of silos? That's number one. Number two is, it was brought up earlier in this wonderful conference, how do we leverage every aspect of telecare, and in our case, telerehabilitation, to deliver more practice to many individuals? And how do we understand who is not going to benefit from it? Who needs an alternative level of care? What is the particular characteristics of people who are more cost effective on tele or would benefit greater for them and their families, and who is not? And then even more importantly to me is to understand again this at-risk population of people when these things come back again, and come back and really have a true strategy that if we get hit again, we know that we have to go to certain places first, and we've got the data and the interpretives to do that.
Okay, one last question. We have to go quickly here. So just the best lesson that you learned, the thing that you're going to carry forward with you into our next scenario. Theresa?
Trust your colleagues.
Karen?
We can do anything as a team.
And Ross?
Mass General is family. The unachievable is achievable.
It's wonderful. I'd really like to thank all of my wonderful colleagues this afternoon for their great commentary. We're very proud as a team and as a system that we've been able to provide this care. We look forward to continuing that great work in the future, and we thank everyone for their attention this afternoon.